kind of a happy coincidence.
Is it okay if I record? Because I don't want to miss anything you say.
Yeah, of course, of course.
All right.
If you need me to repeat anything, just ask.
You could start over, and that would be great for way for me to introduce you to other people as well, not force you to go through this again.
My name is Dr. Robert Groysman. I'm a medical doctor, MD. I am first generation, born in Ukraine, immigrated to the United States, actually to New York, then New Jersey, back in the 80s, 1980s, and made my way to Texas in 2008. I am a clinical medical doctor. I'm an anesthesiologist and interventional pain medicine doctor. And I've been treating long COVID for about as long as it's been around, a little over 3 years. Our very first patient, even before we knew what long COVID was, or really what COVID caused, just so happened that in January of 2020, we had a patient with PTSD, and I've been treating that with the stellate ganglion block, which is an injection I'll go over here in a minute, but it's basically an injection in your neck. And he happened to have reported loss of smell and taste, which in the beginning was just anosmia and ageusia, no other symptoms. And we didn't really make the connection with COVID at the time. And after the block, both his taste and smell were restored. So it's kind of an interesting finding. And I guess when long COVID was finally made known as a diagnosis in May of 2020, and in fact, it was jokingly known as, you have COVID if you lost the smell and taste.
Right, right.
It wasn't technically long COVID, but it was part of the initial infection if you didn't end up in the hospital.
Right.
So we expanded on that and been treating long COVID ever since. Had several additional treatments, including vagus nerve stimulation, including the FLCCC protocol, including peptides, and gut health is very, very important in long COVID. So that's kind of me in a nutshell. I can tell you a little bit about the stellate ganglion if you like.
Yes, that would be awesome, because I know a lot of people would have questions. What is involved in that? How does it differ from, let's say, injection for like a swollen disc or something? How is it different from other joint injections?
Sure. So it's a relatively quick procedure. It takes 10 to 15 minutes for an experienced provider like myself. It has to be guided. So I use ultrasound guidance to avoid some of the major vessels and nerves in the area. So essentially, it's a bundle of nerves that sits on the front part of the spine. Or actually, I should say, front part of the vertebral column.
Okay.
And it sits right at the junction between the neck and the thoracic region of the upper back.
Gotcha.
Basically right at the shoulder level. And this bundle of nerves acts as a relay. It controls signals that come from the rest of the body to the brain, and from the brain to the rest of the body. This is where all the sympathetic nervous system, the fight or flight response, communication basically goes through.
Okay.
And when it's not functioning properly, one thing that can happen is that the fight or flight doesn't just happen once in a while when you need it. It happens and stays the majority of the time. So instead of it being available to the body 0.1% of the time, it's available to the body 99.9% of the time.
So it's like a gas pedal stuck
Yes.
on Zoom.
Yes, and once the fight or flight is basically in a constant on mode, the rest of the body also responds, including epinephrine. So you have epinephrine dumps. Your adrenals are forced to work much harder. which are the glands that sit on top of your kidneys that produce epinephrine and norepinephrine. And you have trouble sleeping. You have issues with
anxiety, maybe, or
yes, anxiety, and basically any of the neurological symptoms that we see, such as chronic fatigue, excuse me, like brain fog.
would they see some of the tremors we've been seeing in folks, like that come out of nowhere, or when they talk about that shocking feeling, like they feel like they're being zapped up their spine, down their spine? Is that a different type of signal, separate issue?
I think that is caused by basically a neuropathy or radiculopathy, basically inflammation of the nerves that being in chronic sympathetic state promotes.
Okay.
And not only that, but it also promotes autoimmune conditions or autoimmune situations where people are getting sudden onsets of rheumatoid arthritis, diabetes, type 2, they get lupus, they get Sjogren's, they get thyroiditis. They've never had it before. They've never had any problems with autoimmune problems before. All of a sudden, all these things start popping up. This is a consequence of having the sympathetic nervous system essentially going haywire.
Gotcha. Okay. So if we go back to this stellar ganglion block, could you run down, is it under, you mentioned it's guided, is it fluoroscopy or ultrasound? And do you numb the area? Do you have to numb the area, or can you give some more details? Because I think folks would like to know what to expect.
Sure. I mean, it can be done with a fluoroscopy, but with x-rays, you don't see muscle, you don't see nerve, you don't see blood vessels.
I see.
And
So
the area we're talking about is about a 2-inch by 2-inch box.
gotcha.
So the important structure is kind of in the way, would be the carotid artery.
Oh, so you definitely want the ultrasound guided.
Yeah. There's a bigger, more important artery called the vertebral artery that actually communicates with the brain. There's the jugular vein, the internal jugular vein, and there's your brachial plexus, which is the nerves that come out of the cervical spine that form the nerves that control your shoulder and arm. All of those things are kind of in the same area. There's your esophagus and your thyroid gland, which are all kind of in a small area. So yes, I recommend ultrasound. That's what I use because all these things are visible, and avoidable. Sometimes there's extra blood vessels in the way. They don't necessarily have a name, but they're ancillary or accessory veins and arteries. Injecting into an artery would be very bad because it can cause a seizure.
Okay.
So yes, so the procedure is simple. Locate the proper vertebral level with ultrasound and numb up an area of skin, and then use an ultrasound visible needle to guide it to where the sympathetic tract is, and then deposit the local anesthetic, and then remove the needle. Okay.
How long is the recovery time?
There really is no recovery time. It's basically an injection. So the only recovery time, I guess, if you want to consider recovery time, some people will have more fatigue initially because their body still needs to make up all the sleep that the sympathetic overdrive caused. But so after the block is done or almost to the completion, what we'll see is what's called Horner syndrome. So in this particular context, what that means is that the sympathetic output has been stopped and it's no longer reaching the face, head, neck, brain. So what that does is it makes the side that's blocked, it makes the eye droopy,
I see.
and it makes the white of the eye, the sclera, red or bloodshot. It makes the pupil smaller, and it makes the nostril on that side stuffy because the sympathetic nervous system prevents the engorgement
Okay.
of the nose mucosa. And
Okay.
sometimes we'll see flushing or increased temperature on the side that we block. So half the face or neck or shoulder will turn red or flushed because, again, we're opening up blood flow to the area.
Gotcha.
So those things are expected and something we want to see.
Okay.
So
those symptoms sort of tell you it's working, the medicine got to the right
yes,
area. Okay.
yes. I mean, for me, it happens pretty much every time. I haven't had one that doesn't. But one unintentional consequence of putting local into the area is because it's so close to the voice box, the larynx, is that there's a nerve there called the recurrent laryngeal nerve, very small, and it controls the vocal cord, and it invariably gets blocked also.
Okay.
The proximity of where we're putting the medicine in, and that nerve, when it's blocked, it feels kind of like a lump in the throat or a frog in the throat or hoarseness. Some people feel a sensation like it's difficult to swallow, but it really doesn't involve swallowing at all.
Okay.
It's just a sensation.
Gotcha.
And sometimes we do block both sides, but not at the same time because of that reason.
Gotcha.
You do not want to block both vocal cords at the same time.
What would be the timing between the two different injections? How long would they have to wait?
It's a factor of the duration of the local anesthetic action. So I use ropivacaine. So on average, it's about 4 hours.
Okay. So they could have this procedure done on the same day, or would
Yes.
they have to? Oh, okay. Because a lot of people end up having to travel for long COVID treatments, and I know they would be excited to get a treatment that uh, could be affected in the same day because travel is so
Right.
hard on them.
I mean, you can always use something like lidocaine, which gives you about half an hour in between. But I picked the middle of the road with ropivacaine to give them the best chance of getting the pedal unstuck, so to speak.
Gotcha. Some so there's like no steroids in this treatment, is there? Because some folks with some of the unique symptoms that can show up with long COVID have sensitivity to steroids at some point. There's always somebody that has some unique requirement. Are there other medications besides the ropivacaine for this block?
There's other medications. I don't personally use steroids. I know some doctors that do. The system is not necessarily inflamed. So unlike doing an epidural or a joint injection, as you said, we use steroids for that to decrease inflammation in the area. There's really not, there has been shown to be inflammation in the stellate ganglion or the sympathetic tract. So why introduce a new medicine or chemical that's not needed?
Right. Okay.
You can use pretty much any anesthetic that you would use for any other injection. There's lidocaine, there's bupivacaine, which is also called Marcaine. There's ropivacaine, what I use because it's technically a bit safer than bupivacaine.
Okay.
There's mepivacaine.
Lot of choices.
Yeah, there's a lot of different anesthetics you can use, and they have different durations.
Okay.
So this injection differs a bit from the typical block that we do for pain management of other things. So when we do an epidural and when we do a joint block, The steroid is included to give it the duration. In other words,
Okay,
so once the local wears off, the symptoms don't come right back.
okay,
But in this particular case, it's a whole reset, and you don't need the steroid to maintain the duration.
okay. That is really fascinating technology that you can provide. And another treatment people have been looking to, that I guess some doctors use the ultrasound guided for the migraines that people are having with long COVID. Do you handle those treatments as well? Like the Botox injections for migraine or other treatments for migraine? I know some doctors use ultrasound guided injections so that they can do exactly what you said, get the medication into the right area, as opposed to what the pamphlet comes from the company that makes Botox. Doesn't really mention ultrasound guided anything. So I could see how you're offering to patients with ultrasound guided injections can work for other things. I don't know. You tell me, is that something that is being used for long COVID patients?
So when you're referring to Botox injections for chronic migraines, you don't use ultrasound for that because it's very superficial.
Okay.
It's about 31 injections with a very small needle, like a 31 gauge, very small, smaller than a hair. And you inject about 155 units, so a lot more than you would, for instance, use for forehead or crow's feet or for things that, for cosmetic purposes.
Okay.
And the injections basically go around the head, including the sides, including the back of the head and the shoulders and the back of the neck. But those are really meant for chronic migraines or a daily headache,
Yeah.
something that occurs very often. The ultrasound guided procedure you're talking about, you can do a sphenopalatine block. Now, some doctors you can stick swabs up the nose, but the latest research shows that it doesn't really penetrate as well as once thought, and the medication doesn't really get to the sphenopalatine ganglion by going through the nose.
Okay.
So what I do is I'll come from the outside and inject like so into the area where the sphenopalatine ganglion is to get a much better result than going into the nose or spraying into the nose or putting pledgets into the nose. There's that is a one way to tackle migraines as well.
One other similar, I guess, another symptom people have been indicating a lot of lately are things related to trigeminal nerve pain, facial pain in this area. Is that something you also can help treat?
Yeah, so when you're doing the sphenopalatine block, you can technically target the trigeminal ganglia as well in the same area, or very close.
How long of a relief time do you get with these blocks? Are they like something you have to do every few months or once a year? Or how many do you generally need to get like sustained relief in your experience?
Well, since we're not completely sure why these headaches occur during long COVID or after long COVID, it's really not clear how long the block would last. But in general, it's anywhere from a couple of weeks to a couple of months.
Okay.
If we're talking about stellate ganglion block, it may be even permanent. Even after even after one injection, it can revert back to the old symptoms And the way I look at this is it's kind of like, door's stuck, it's locked. So you unlock the door and you pull it. And let's say you can get it pulled open, but there's a rubber band or rubber, I guess rubber band between the door handle and the door frame. So
Gotcha.
it constantly resists being opened and it wants to go back to where
It
it's
was,
used to,
gotcha.
even if it's abnormal. Your body likes equilibrium, even if it's been abnormal. So if you make it easier for it to close, such as, um, stressful life, or just
Reinfection, maybe reinfection. Quite a few folks
reinfection,
are getting reinfected.
yeah, reinfection of COVID would do it. You don't even need COVID.
It could be,
Any kind of respiratory illness or anything that involves the upper half of the body can do it.
okay.
Um, injury, surgery sometimes do it. And sometimes it just happens with no clear reason, just because it's really sticky and wants to close back up. So there's been some success with repetition. Repeating these blocks in sequence can sometimes help basically reteach the body to keep it open.
Now, another key question folks would ask, is this treatment something that insurance would cover? Or is it like considered a novel treatment? Or, like many folks who have long COVID now are on Medicaid and Medicare or on some HMO health insurance. And then there are some that don't have health insurance at all. What kind of options are there for these
So,
folks?
so this block, like I said, I've been treating PTSD with for many years before long COVID, at least 10 years worth, and insurance still has not even covered that. Now, some VAs cover it, but for the most part, it's not covered. It's not technically experimental anymore, but okay, let me backtrack. Stellate ganglion block has been around since 1930. It's approved for, yeah, but not done the same way.
Okay.
Obviously, it's much safer now than it was back in the 30s. But sorry, let me train of thought. So they approve it for pain syndrome. So
Okay.
things like a nerve injury or CRPS, which is chronic regional I forgot what the P stands for.
Oh, I chronic regional pain syndrome, I think.
Pain syndrome, yeah.
Yes, yes.
So that something like that, it's approved for, and they don't approve anything that's not pain related.
Okay, well, there's definitely a lot of pain involved with long COVID. I have not seen
Agreed.
anyone
Right,
who
agreed.
doesn't have some form of pain. That's another interesting thing that you mentioned. Uh, a lot of patients are looking to either get into a long COVID clinic or to get a long COVID diagnosis to begin with. And uh, our understanding is that any doctor can make a diagnosis of long COVID. But most groups prefer a specialist. Like a lot of primary care doctors are referring that diagnosis out to a specialist like yourself, or rheumatology, or
Neurology.
yeah, neurology. A lot of the organs and treatments that you handle all overlap each other because it's all the human being. So would your practice be able to help these patients get the diagnosis for long COVID, since you are very much working as a clinical anesthesiologist, helping patients to diagnose what's wrong with them and help formulate treatments? Would you be able to help them with that so that they can get started on getting disability and getting, a lot of people want some avenue to get back to normal life and get treatments. And with the pandemic recently being declared over, but COVID is not over, and the COVID infections are clearly not over, but the pandemic emergency has been declared over. A lot of folks have lost their Medicaid insurance, and there have been a lot of changes to their life overall. So is that something your practice does, that you can evaluate that the person has long COVID?
Well, the short answer to that is yes. And this is kind of what I do day in and day out.
Okay.
So let's talk about long COVID in general, the diagnosis.
Okay.
The clinical diagnosis. There's no specific even criteria for it, except that you have to document either infection with COVID in the past, or there's also a post-COVID vaccination syndrome, which happens in a small percentage of people who have been vaccinated from COVID or against COVID, and symptoms are very similar. So it's really symptom driven. There's no lab that's a biomarker in the blood or urine or anything. There's no imaging from MRI, CAT scan, or X-rays that would be diagnostic. So it really is very much so a clinical diagnosis. So because of the clinical diagnosis and there's no specific diagnostic criteria, it makes it a very difficult thing to diagnose across, basically across practices. I mean, yeah, I realize that the administration has decided to say that the epidemic is over, but it's really far from over. COVID is now part of our landscape. It's going to be part of our landscape for many years to come. Long COVID still happens and exists, and there's new people getting long COVID constantly. Conservative estimate is 65 million people worldwide. 65 million.
Newly disabled, yeah.
But have long COVID though.
Right.
And you know, that's a conservative estimate because some people don't come out and say they have it, or they've been infected, or they're debilitated. And yes, long COVID is very debilitating. It has a lot of morbidity associated with it, right, because of its neurological impact. People are unable to work. I mean, I see this all the time. They're not able to think or perform their jobs because of the brain fog or the chronic fatigue. They're not able to move around much or exercise or lead an active lifestyle because of the myalgias, the arthralgias, involvement of joints, muscles, and the neuropathies. And this is all chronic inflammation. Some of the joint stuff could also be from rheumatoid arthritis, again, the autoimmune element of it, or lupus, because that can attack joints as well. And yeah, I mean, it's really creating a lot of problems for people and for businesses, because unemployment is obviously much higher because people just can't work. Right. Or there's offices where you know, the smell and taste issue, which we didn't even really dive into, but if you have parosmia and everything smells like skunk or garbage or raw sewage, It's very hard to tolerate being around people who wear perfume,
right.
or
Or
there's
even,
any food
yeah,
being cooked in the kitchen.
or yeah,
It's
even be a chef. I mean, your career is pretty much messed up because a lot of people are in the uh, restaurant industry, and their, I guess their skill is combining seasonings and spices and cooking to perfection. They can't smell it anymore, and they basically lost their way of making a living.
yes, yes. In those cases, if you're a chef or you cook for a living, yeah, it's really career ruining in a sense. But my feeling on this is that the smell and taste is a functional problem, not a
Okay.
structural, because we've analyzed basically the structural component, and for the most part, it's intact. Now, some people do have some epithelial damage or the support cell damage, but that could also be from the chronic inflammation in the area.
Right.
So many people do recover their smell, or basically the parosmia goes back to either normal, which is the ideal, or at
Right.
least not offensive. So it may not taste or smell like you're used to smelling and tasting, but it won't be offensive anymore.
Um, you mentioned the gut health and the importance of that. That's one of the things that um, I have great interest in, and I think it is a critical component to any sustained results. Um, how do you incorporate that in your practice? You mentioned uh, functional medicine, I believe. Uh, I know you mentioned gut health, so if you could tell us your interest in that and how you incorporate it to help patients.
Okay, well, how much time do you have? I'll try to
Um, mm,
consolidate.
uh, what I'd like to do is just like pause so I can, uh, I was, my Zoom is like limited for 40-minute call, and I wanted to extend that out, and
Sure.
and I think folks are going to be fascinated to hear anything that is of hope, and what you're doing um, is pretty spectacular.
Send me another link, or we.
Yeah, let me do that. If we can
Okay,
just take a short, like 10, 15-minute break and then resume, and you can tell us a little more about your practice and how folks can uh, can make appointments with you. Do they have to only live in Texas, or do you take patients from all over? Do you offer telemedicine? How long is the wait time? People are going to have all these kind of questions. And
sure.
once they find out, you have empathy for them. You believe that there is a condition called long COVID. Um, they're going to be racing in droves to see you. So, as you mentioned, the 65 million that's on the planet, there's probably at least, I would say, 15 to 30 million in the US alone, based on how many people got COVID. Theoretically, anyone who had COVID could potentially develop long COVID. And we're not even considering the post-COVID vaccination syndrome. So,
Right. And that's a lot of it is driven politically, unfortunately.
right,
Um, but there's a significant portion of people who have been vaccinated, who
right,
have basically the same symptoms of syndrome
right,
as people who have been infected with COVID.
right.
It's still being denied by a large part of the medical community, but the evidence is there if you look.
Yeah, I firmly believe it. I hear it all the time. and if you can't deny the symptoms that they have and what they're going through. And I'm so glad that I'm so glad I've met you, and that you care so much about your patients and the other patients, and have something that can be done now to affect change in their life that
Well, there's more things we can talk about, kind of
yeah,
what works and doesn't, but let's go ahead and take the break so you can
sure. And we can,
reset.
yes. Thank you so much, doctor.
You're
I
welcome.
appreciate you. Be
Bye
back
bye.
soon.